Welcome, everyone. Welcome to the Society of Thoracic Surgeons, the Congenital Heart Surgery Database monthly webinar. Today is June the 21st. I cannot believe we are already halfway through June. All right, on the agenda for today, just have a brief STS update, then I'll share some information about AQO. Then we'll turn things over to Chastity for our STS education. We don't have any updates from IQVIA today, so we'll, after Chastity's education, we'll wrap things up with your Q&A as usual. So again, please be sure to submit your questions via the Q&A function. If you have an outstanding ticket with IQVIA and you'd like an update, please feel free to put that information into the Q&A. You can include your ticket number and someone from the IQVIA team can follow up with you directly. On the call with me today from the STS side, we have myself and Carol Crone. We have Dr. Jacobs, we have Addie Dolan, we have Chastity. We also have Leslie and Janet from the core group side. And then also we have Melinda joining today. And from our IQVIA team, we have Jean, Joe, Michelle, and Madri, it looks like. So, all right, I don't think I'm missing one. So thanks everyone for joining today. All right, for our STS updates, just the June, you guys are fully aware, the June training manual has been posted and is available out on the STS website. I don't have any additional information right now regarding the 2021 harvest analysis update. Again, those results are expected to be available in early summer. So of course, those will be available to you all prior to the spring 22 harvest close. And again, more information about all of that will be coming as soon as possible. So of course, STS official notification will be sent regarding the analysis results. Also, in regards to the release of that 2021 harvest analysis update, our harvest close date, our current harvest close date, will be determined based upon when those 2021 analysis results are released. So of course, we have our task force call on Monday night, I believe Monday or Tuesday night of this week. I think I have two that week, so I get them my thoracic and congenital flip-flop sometimes. So we have our task force call next week. And of course, after that task force call, we'll be making some decisions about the current harvest close. So more information will be shared with you all in an official communication after our task force discussion next week. So stay tuned for all of that information that will be forthcoming. Our 2022 audit update notification letters will be coming soon. We have our kickoff call at the end of this month with our surgeon leaders. So audit notification letters, you can expect those to be coming out the 1st of July. So stay tuned for that. Also, the 30-day status verification, I'm not going to go too much into that. Chastity is going to present all of that information here coming up in her education. So just know that the 2022 audit letters have not been sent out yet. They will be coming the 1st of July. So again, be on the lookout for those. Those will be sent. Audit notification letters are sent to the primary data and file contact and your surgeon representative via email. So those would come from Emily. So again, audit notification letters will be coming within the next few weeks. So look for those around the 1st of July. AQO 2022, I do have an update. Emily's not able to join us today, but I'm going to write an update on her behalf. So as you're all aware, our AQO is coming up October 26th through the 28th, and it's going to be held in Providence, Rhode Island. Abstract, we are currently accepting abstracts for AQO this year. The submission deadline is Tuesday, July 5th. All of the information that you need to submit the abstract is out on the STS website. We just have a snippet here from the page. Again, all of the information can be found out on the STS website, all the abstract guidelines and the submit abstract button here. And again, deadline is July 5th at 11:59 p.m. Eastern Time. AQO registration is currently open, so the prices are listed here. And again, this information is all out on the STS website. So to receive early bird registration, you need to register by Friday, August the 26th. And here we have the pricing for 1 track, 2 tracks, multi-day, and then the virtual pass for our STS members versus our non-members. So the early bird pricing can be found here in this column, and then our regular pricing after the August 26th deadline can be found over here in the right-hand column. So again, all of this information is out on the STS website for you to go back and review if needed. Marketing was kind enough. We've had a lot of questions on what's the difference between the in-person versus the virtual pass. As you know, we are doing kind of a hybrid AQO this year. So obviously we would love to have you all join us in person. So again, marketing has gone through and kind of identified what you get at AQO versus in-person versus by purchasing the virtual pass. So I thought this was a great visual to share with you all so you can get a quick glance of what you get at in-person versus the virtual pass. Again, by purchasing the virtual pass, this will not be a live, we won't be able to stream live at the in-person meeting. So you will have recorded content from the in-person meeting that will be available mid-October. So with the on-demand content, the on-demand content will be available to everyone mid-October, but the recorded archive of the in-person sessions will be available to you all in mid-November. So the live in-person meeting again takes place in mid-October. If you do the virtual pass, you will have access to all of that content available to you in mid-November. So again, we would love to have you join us. Obviously, through the in-person sessions, you'll have networking reception, you'll have access to the speakers, the live Q&A, the personal interactions, the networking with your peers, as well as your colleagues, the speakers. You'll have FaceTime with the exhibitors. We'll have the giveaways and passports to prizes. So again, if at all possible, we would love to have you join us in person. We'd love to see your faces. So again, this information is also out on the STS website as well. Just to give you a quick preview of some of the preliminary program topics that we've been discussing. These are just some of the things that we have that we're working on right now. And also I wanted to give a quick thank you to everyone that took the time to complete that survey. We greatly appreciate that. We're going to be using that feedback in our next AQO planning call coming up I think in a couple of weeks. So, but right now where some of the topics are implementation of the new stat scores, adults with congenital heart disease fields, the version upgrade. We're going to be including case scenarios, morbidity. There'll be a session on 30-day follow-up and best practices for 30-day follow-up, anesthesia, audit information, an update on the volume project. As also, we'll have some presentation by data managers on how to use your data for everyday practice. So again, these are just some of the topics that we're looking at and discussing and working into the program. But again, thank you to everyone that did take the time to complete that survey. We'll be looking at all of that feedback in our next planning call. So just to give you an idea of what we're looking at. Also, educational sessions and social events will take place at the Rhode Island Convention Center. We have reserved a block of rooms at the Omni Providence Hotel, so that special group rate of $259 is guaranteed through Tuesday, October the 4th. So we do invite you to go ahead and look at getting your room reserved. You can reserve online via the link here. And again, all of this information can be found out on the STS website. And also, we would like to invite you to check out, there is like a little microsite for the STS. If you would like to, we invite you to go check out and see what's available at Providence, things, attractions, dining, hotel information. So we do invite you to go and check out that little microsite as well and learn about Providence before we get out there. So we invite you to check that out as well. And I think that's all the information that we have for AQO. Again,
I have something.
Oh yeah, Carol. Yes, ma'am.
Sorry, I don't know if we have a slide yet or not for this, but AQO is going green this year.
Oh yes, thank you. I forgot that. Yes, ma'am.
Oh, go ahead. You
No,
can take it.
No, knock it out there, Carol.
Sure. AQO is going green this year, so we will not be printing information or agendas or the data collection forms like we had in the past. So we asked if you do want to bring, we will have QR codes. You can scan those with your tablet or your phone. Obviously, the DCFs on a phone is kind of difficult to see, but you could also print them out yourself and bring it with you. We will have a pen and paper available. I think that will be the giveaway. And then also looking at making sure we have charging stations if you're bringing your computers with you to be able to plug in. We're still working out all those details, but just a heads up that we are going green this year. There will not be handouts or printed agendas. Everything is going to be online. So.
Okay, great. Thank you, Carol. I totally forgot to throw that that information in there. So I'll add that slide prior to posting for the recording, so that is out there as well. So thank you. And is the justification letter available on the STS website for AQO? I know there will be one. I don't know if it's out there just yet. Carol, do you know if Emily has
I don't see it yet, but I think you can contact Emily and she'll be able to get it to you as soon as it becomes available.
Yeah.
And I'll put her email in the chat box.
Thank you.
Mm-hmm.
All right. Alrighty. So next I'm gonna turn things over to Chastity for her STS education. Chastity, the floor is yours.
Leanne, thank you very much. So today we are going to talk a little bit about the Starnes procedure and clarify the coding for this procedure within the database, as well as we are going to take a deep dive into the database audit policy that was just released. And I know we've had lots of questions about both of these, so hopefully it's timely and appreciated by everyone, whether you are an expert or novice in this database. Next slide. So again, let's start with our Starnes procedure coding clarification. Next. So what is a Starnes procedure? As you know, we don't have a code that is specific to this procedure called out as a Starnes procedure within the database. So while I do not pretend to be a congenital heart surgeon, we do have a few on the call. So if you want more information regarding a Starnes procedure, I am sure that they would be more than happy to answer questions regarding the specifics of the procedure. But in essence, the Starnes procedure is performed as surgical treatment for Ebstein's anomaly, as well as some other anomalies. And usually this is more severe courses of the disease. And so very basically, the surgical technique is that we are going to do a fenestrated patch closure of the tricuspid valve, a VT shunt or some type of systemic to pulmonary artery shunt, an atrial septectomy, a reduction right atrioplasty, and whatever type of needed procedure in the right ventricular outflow tract. And so again, this is usually done on patients with Ebstein's anomaly where the tricuspid valve is not amenable to repair, or the functional portion of the right ventricle is not adequate for repair, or perhaps the right ventricular outflow tract obstruction is not easily repaired either. So this is what would lead a program to determine whether or not to do a Starnes procedure. Next slide. So I've included just a picture here of normal heart versus Ebstein's anomaly, where you can see the tricuspid valve is misplaced down into the right ventricle. So just for fun. Next slide. Couple pictures then from the Starnes procedure itself, where you can see the fenestrated patch over the tricuspid valve and then the placement of the aortopulmonary shunt. Next, and that is all my surgeon knowledge that I can impart on you. So in the database, as I told you, we don't have something that is specific to call out Starnes procedure. So there are two different repairs that are included in the database. And so we have procedure code 465, which is Ebstein's repair. And if you read it, you realize we talk about, repairing the tricuspid valve for Ebstein's, repositioning of the tricuspid valve, and doing many of the other repairs that would be needed to address the Ebstein's anomaly. We also have the elusive 480 valve closure tricuspid exclusion univentricular approach. And with this, you can see that this is where they are doing the patch closure of the tricuspid valve. So as you know, if you have been paying attention to the training manual, many of us have followed this because of the top line under Ebstein's repair to ensure an accurate account of repairs of Ebstein's anomaly, use this code. And so many of us have gone on and coded Starnes procedures as Ebstein's repairs. As well as if you are a long list user provided by some of your vendors, you know that if you put in Starnes procedure, because in the long list you can get to it, it actually maps to 465 Ebstein's repair. So we are here to tell you that that is not what should be happening. So next slide. We talked about this tremendously on the most recent core group call and came to the conclusion that the Starnes procedure really should be coded as procedure 480 valve closure tricuspid. And then you're going to have to code the other procedures that are completed as separate procedures. So the systemic to pulmonary artery shunt, the atrial septectomy, and then any included right ventricular outflow tract procedures. So what's going to happen in the database? So we've now clarified the definition. This will get put into the training manual. It will go live, I guess, the first week of July. And then, so the recoding of data, we recognize that for any one program, there's probably a very small number of these procedures that are coded incorrectly. Because we've made a clarification to the definition, it's the STS standard, that it is up to the sites to determine if they want to go back and recode previous procedures that they perhaps have coded as Epstein's repairs when they should be the tricuspid valve closure repairs. So again, we leave that up to your sites if you want to go back and recode that data or not. And so are there any questions about this? I could take some questions now if there's anything related to this. Or I have surgeons on the line that are willing to talk more about Starnes procedures. As far as the long list being updated, we know that the long list will be updated. For those of you that have vendor software that utilizes this long list, you'll have to work with your vendor then to on how that will be updated within your software. Because of course your software is still going to say if you've done a Starnes procedure, it will map to the Epstein's repair. I think I saw, go back one slide. Oh, is it this one here? So,
yeah, Jocelyn had asked to go back one slide, so I went back. So
perfect,
just to get that
perfect.
clarification.
And I see Dr. Meyer has his hand up.
Yes, Dr. Meyer. Oh, I think I have to unmute. Oh, hold on.
No, I'm okay. I mean, I'm not showing myself as muted, so can everybody hear me all right?
Yes.
Okay. So you may wonder, where did this come from, this change? And I think it was primarily because of the recognition that this group of patients who are getting this operation typically are extremely ill in the neonatal period, frequently don't survive, I would say, and it seemed wrong to lump them together with all the patients who are having Epstein's repair, who might have it at age 2 or age 20, and who are obviously quite a different patient population in terms of how sick they are going into the operation, as well as having a really quite different functional outcome. You know, these patients who have a Starnes procedure are effectively like a palliated single ventricle, like a stage 1. Whereas, you know, the patients who have a regular Epstein's repair by cone technique or any of a number of others, at least theoretically, have a 2 ventricle circulation. They have the 2 circulations mostly, if not completely separated. You know, it's just physiologically quite different. And so as a consequence of that, you know, we thought that it was inappropriate for this other subpopulation of sick neonates with gigantic hearts and not infrequently pulmonary underdevelopment, because the heart is quite large even during development, that it didn't seem biologically correct, if you will, to lump those in with all those other patients undergoing an Epstein's repair. And so this alternative code that we had available was the one that was chosen. I'd be happy to take any questions if anybody, you know, wants to discuss further.
I'm not seeing anything yet, Dr. Meyer. Thank you so much for that. I greatly appreciate.
Yes, thank you. And thank you to the data manager who I believe was just last week or week before last that brought this question, and we realized that we needed to address it. So thank you for bringing it forward. We appreciate your questions. It makes us think, make things better. Okay, so let's now move on then to the audit policy. And so we're going to talk kind of globally. The policy is the same regardless of which STS database you participate in, but I will highlight some things that are native to the Congenital database. So first off, the new audit policy is posted on the STS website, and I provided the link over here in the slides. But if you just go to the national databases on the STS website and scroll down, you will see that there's a whole section dedicated to audit. So you're going to want to go there and really become familiar with this site. So why do we do audits? For those of you who haven't yet had the privilege of undergoing an audit, you will know that the database audits serve two purposes. So one is to ensure data accuracy. This data is used for, for research and publication and advancing the science of congenital heart surgery or all heart and thoracic surgery. And so we really want to make sure that we are providing accurate data so that the analyses can be done appropriately. The databases are also a really great educational opportunity. So no matter how long you've been doing this database, we all clearly, based on the Epstein slides I just presented, have opportunities that we can learn from. And so I don't think any one of us knows everything about this. And so it is really nice to have, some one-on-one time with a surgeon auditor, as well as just the auditor themselves to come in and perhaps impart some knowledge that you didn't have, or can also programmatically help you, how better could you do a certain procedure or function within the database with data collection or following up on your patients and things. And so I think that they are a really good educational opportunity. They also are a requirement in our participation agreement. So you can find this language in your contract with STS, but approximately 10% of sites within each of the individual databases will be selected for audit annually. Next slide. So how do you get selected? So the sites are selected randomly from the eligible audit pool, and there are inclusions and exclusions for the audit pool. So if we look at the inclusions, you have to have been an active participant for all 12 months of the audited time period. So if you are a new site that started 3 months ago, you're not going to be included in the eligible pool for audit. You also need to capture the specified minimum number of procedures or admissions during the audit time period. So specific to the Congenital database, this means you had to have completed at least 30 index operations over that 12-month audit time period. So what excludes you from the audit pool? If you have successfully completed an audit within the previous 3 years. So the nice part is if you were audited last year, you will not be audited this year if you successfully completed that audit. If you were identified as a site that did not meet expectations during a recent audit, you also don't go back into this eligible audit pool. You'll be re-audited at a different time frame based on your audit results. It's also important to note, if you read the audit policy that is posted, that STS does reserve the right to perform a random audit of a program. And this can be something that STS just deems appropriate for a program, or you as a participant can ask for an audit. And so again, we can work with Emily to figure out those things if you indeed want to bring an audit upon yourself. Next slide. So as far as the Congenital database audit goes, this is what's going to happen. You would receive a letter that says that your program was selected to receive an audit. It will include the surgical dates this time around in 2022. It will include the surgical dates of July 1 of 2020 through June 30th of 2021. So we'll only include index procedures that are done during that time frame. They will tell you that there will be 20 randomly selected index operations for audit. All of the mortalities related to an index operation that's done during this time frame, as well as a review of your operative case log. Next slide. So for those 20 index cases that are cited for just a general overall audit, these are the fields that will be looked at. So it's not every field within the database, but I've listed the fields here, and I know it's a lot for this slide, but again, if you go to the STS website, you can find all of this information. I pulled it directly out of there, but you can see what kind of information the auditors will be looking for those 20 randomly selected index operations only. Next slide. So if you looked at the bottom of the previous slide, there were preoperative factors and complications, and in parentheses, there was the word select. So there are only a select few or lots of pre-op factors and complications that are going to be audited. So again, it's not every preoperative factor, but it's the preoperative factors listed here. And then on the next slide, it is the complications that are listed on this slide. And what you're going to notice about the complications are these are the identified major complications in the congenital heart surgery database. And so you probably know these, you know, if you've been doing this a while, you probably know these off the top of your head, but the sequence numbers for the fields are there. In addition to, if you look at unplanned interventions, you see that it includes 22, 24, 26, and 240. And so if you have those memorized, like some of us sadly do, you know that that's an unplanned cardiac re-op, an unplanned interventional cath procedure, an unplanned non-cardiac re-op, and bleeding requiring re-op that all get included under unplanned interventions. As far as acute renal failure, it is all types of renal failure that required some type of dialysis, whether at discharge or just transiently. And you can read the rest. I don't need to read the slide to you. But again, it's not every pre-op factor or complication that will be looked at. Next slide. So when they look at the cases then that were all of your mortalities, so that number will depend on how many mortalities related to an index operation that your program had. And so if you are a site that during that surgical year, you know, only had a small handful of mortalities, it's easier than if you've had a larger handful of mortalities. But again, only a finite number of fields will be looked at for mortality. For those mortality cases. And so again, these are many of the things that we collect in the database, and you're going to want to make sure that you are providing documentation back to the auditors of how you elicited this information. And so obviously these are things like your admission H&P and your op notes and your discharge summaries and things like that. And so again, this is your guide if you know which fields are being audited of what type of source information you're providing back to the auditors. Next slide. Okay, so how are the audits scored? So of course, they're not only looking at data accuracy, but they're also looking at data completeness. So when we talk about data accuracy, and the definitions for this are all very nicely written out in the audit policy, which is posted on the website. But data accuracy, you're really looking at, does your data match what the auditors think should match? And there are acceptable variances and things. And again, I urge you to go out and read that policy so you can see what's acceptable or what would not be acceptable. This is different from data completeness. And so how complete is your data are, you know, many of these data fields that they're looking at blank. And so that doesn't mean it's inaccurate. It means that it was never coded. It was never completed. And so you get a score for data completeness. And then the data completeness of the case log. So you're going to provide an operative case log directly from your OR software or however your hospital does this. And you're going to provide it to the auditors who then look at the index cases that were submitted in your data file. And they say, gosh, you have, you know, all the cases match, or perhaps there are cases on that case log that don't show up in your software. And you have an opportunity to explain this. You know, oftentimes things stay, like at my own hospital, there may be things that stay on the operative case log, but the case was actually canceled. But you have an opportunity to say that case never occurred. You know, there was an emergency that happened up in the cardiac ICU as this patient was rolling down into the OR. So instead we turned around and took that kid back to the ICU, and the case never happened, but it just never fell off the operative case log. And so you have an opportunity to work with your auditors on this type of information. Next. So along with how they score the audit, they're going to essentially give you percentiles of how well you match the data or your data accuracy, or how complete your data is. And then the scoring is you exceeded expectations, you meet expectations, or you do not meet expectations. And within each section, so the overall audit versus complications versus the mortality section, there are different thresholds percentage-wise for what gives you exceeds, meets, or does not meet expectations. Next slide. So when we look at the overall, those 20 randomly selected index operations, you have to have of greater than 98% to exceed expectations, or a 90 to 97.9% to meet expectations, or if you're less than 89.9%, you do not meet expectations. So any site achieving less than 89.9% for their overall site accuracy will then require a re-audit within 1 to 2 years. So you'll be provided with, some education opportunities to learn and kind of revamp your processes, perhaps maybe some understanding of some certain field definitions and things, and then you'll be re-audited to make sure that you then increase your overall site accuracy. Next slide. Complications. To meet expectations, you have to be greater than 98%. If you are between 90 and 97.9%, you do not meet expectations. However, that will be a very big educational opportunity if you do not meet expectations and you're between that 90 and 97.9%. But it does not mean a re-audit unless you're less than 89.9%. Then that requires a re-audit. So again, in this section, if you do not meet expectations, you don't automatically get re-audited unless you're too low. But you could be provided with some, educational opportunities and opportunities to increase your processes and things. Next slide. So for mortality, again, you need greater than 98% to meet expectations. You do not meet expectations if you're between 90% and 97.9%, but you will not be re-audited unless you are less than 89 point or less than or equal to 89.9%. Next slide. Now, here is kind of something new to the audit. All of the STS databases will have a rule that pertains to this, but just different fields that go into this rule. So in the congenital database, we have what's going to be called a mortality post-procedure status verification. And with this post-procedure status verification, you need 100% matching to meet expectations. If you are less than 100% in this post-procedure status verification, you will then require a re-audit. So let's go into some detail about what this post-procedure status verification is. Next slide. So essentially, you are verifying the mortality fields. So where did you get that the patient was alive or dead at 30 days post-procedure, and where did you obtain the mortality status at database discharge? If this is in your EHR, it's pretty easy, right? You have perhaps, a note that says the patient was seen on this day, or you have a note that says the patient died on this day. And so it's pretty easy when it's within your EHR. What is difficult is when it is not within your EHR, but you need to provide some type of source data to the auditors and upload this in your audit file. So whatever that would be. So if you have notes from, an outside hospital and things like that, this is the type of documentation you need to provide so that you are 100% matching this post-procedure verification of 30-day status as well as mortality status at database discharge. Next slide. So I've included a snapshot of the 2 fields from the data collection form. So of course we put in 30 days after surgery, alive or dead, and then how do you know? And you check these boxes, whether it's evidence of life or death in the medical record, contact with the patient or family, contact with medical provider, an office visit, and then the date of database discharge with the mortality status at this database discharge, alive, dead, or unknown. If you do not have documentation of these 2 fields or where you obtained this information that a patient was alive or dead at database discharge and or 30-day status, then you can submit a tracking log. So let's go to the next slide and talk a little bit about the tracking log. The tracking log is acceptable when you don't have any other source of documentation. So this is not the type of thing you want to do for every patient if possible. So this is kind of the last ditch effort. Some of us cannot write in the EHR. So for example, I don't have clinical privileges at the hospital to make any type of notation in the medical record. So if I have nothing else in the medical record that tells me that this patient is alive or dead, I may then personally have to call a pediatrician or another care provider that perhaps is outside of my care system, or I may have to call the parents. And so if I do this, I can't document this in the EHR. I can't have someone else document it because they didn't make the phone call. So I might have to put this on then a tracking log. And so the type of information then that you need to document for this tracking log would be what source you used, the date you identified this source, and then as much detailed information as you can provide that would say the patient status is alive or dead. So I provided some examples from my own tracking log, which passed audit a few years back. So for example, you could say something like on 12/1/21, I made a phone call to the patient's mother, Dawn, reported that the patient was doing well and that they've returned to school. Obviously that 12/1 date occurred, long after the 30-day follow-up and things like that. So you would be able to see those dates in relation to surgical date or discharge date. Another example would be 8/7/22, spoke with patient's pediatrician, Dr. Garcia. The last appointment for this patient was on 8/1/22, no concerns, gaining weight appropriately. And so just the kind of clinical information as much as you can, obtain from whatever source that you're using. Again, this doesn't have to be done on every patient. All of my patients that I have documentation in my EHR, I don't need to do this on. These are for the patients where I have no other source other than to call a patient's mom or call a patient's pediatrician who's not within my hospital system. So during my audit, I had one patient where I had to provide this type of information and documentation because it was not contained within my EHR. So for those of you that have very nice electronic medical records with things like Care Everywhere and some of those other types of features, you're able to get this documentation out and upload it into the audit portal. You only need to provide this type of documentation if you have no other source for if the patient is alive or dead. So next. So again, this tracking log can be any which way you want to keep it. You perhaps have some vendor specific fields in your software and you can keep it there. This can be outside of your software and you can keep it in something like Excel or Word or some other type of document. We know when version 6.23 comes out that there are going to be some site specific fields, and those would be some great areas to keep this information because you'll have a site specific date field and a site specific text field where you can include this information if you as a site want to do that. You don't have to because they're site specific and you can use them whatever way you want to, but that would be a great place to keep it contained within your software if you like that option. The whole point is you must be able to upload this for your audit to show your source of data for proving that the patient was alive at the specified time points. Next slide. So I've been selected for audit. What are the next steps? So the first thing I'm going to tell you is don't panic. They really are painless and educational. You'll spend the most time just preparing for audit and getting all the documentation together. You're going to get a very, very detailed letter with instructions in your audit notification. And so it will tell you step by step with pictures and videos and everything else to figure out how to move through the audit. And again, on the STS website, there are some videos and things already posted to talk about each section of the audit. So if I would urge anybody to go out there and watch the videos and look at all the documents that are available. They're quite informative, but especially if you receive an audit notification. Now is the time to go out and look at all your resources, start asking questions, make a timeline, whatever you need to do to get organized. You may need to work with hospital leadership or perhaps people in your HIM department to get, certain pieces of information out. So don't wait because it will take time for them to get things back to you. And you have very specified timelines and things that you need to get done. So don't wait, don't put it off, start working as quickly as you can. Ask questions. So obviously Emily is available at STS to answer any questions. And then there's information provided for the audit company as well. And they're always available to answer your questions. So my advice to you is to get organized, make a plan, start early, don't delay. Next slide. So just in summary, read your audit policy on the STS website, become familiar with it so you know what's happening. Don't panic. you cannot update any of your data for audit. So for all of the programs that are going to receive notification of an audit for this year, they already have a snapshot of your data. So when you get those 20 randomly selected index operations, you can't go back and clean them up and say, oh, look, I got it all right, everything was good. And they already have a snapshot of your data, and your score will be your score. But what you can do is make sure you have documentation sourced for your mortality validation at database discharge and 30-day status. Okay. I think that's my last slide.
Excellent presentation, Chastity. You did a phenomenal job as usual. So thank you very much. I know we've got some questions coming in. I'm going to, I don't have a lot of information, just one thing.
Really,
quick.
really
go
great. I
ahead.
just want to say really great job, Chastity. Really
Yeah.
covered it well.
Thank you.
Yes, excellent job. So we don't have any IQVIA updates from our previous webinar. So again, just I've seen a few questions come in for IQVIA, and I know it looks like they're being handled there on the back end. So again, if you have any questions for IQVIA, just please submit that via the Q&A here, and Jean and her team can look into that. Just be sure and provide your ticket number. So again, anything that's currently under review, IQVIA will follow up. And again, if you have questions now, just put your ticket number in the Q&A, and Jean and her team will get right back to you. Analysis report questions, you all know just to contact me if you have any questions. Feel free to reach me via email. If you have database operational questions, if you have questions about access to the platform, again, anything participation agreement related, reach out to us at stsdb@sts.org. The one thing I did want to point out, our upcoming webinars, our July 5th user group call is canceled. I think Carol and myself will both be out of the office that day. So that July 5th user group call is going to be canceled. Our next user group call will be scheduled for August 2nd, but in the meantime, we'll have another monthly webinar on July 19th. So our next webinar will be the monthly July webinar on the 19th at 12 p.m. Central, and then our next user group call will be August 2nd at 12 p.m. Central. All right, let's see here. All right, Chastity, looks like we've got some questions coming in. All right, our first question from Patricia. Why has the audit letter been delayed to July when we were told July 13th or 14th? Just trying to plan summer vacations. Thank you, Patricia. I completely understand. Originally, we've had a delay because one of the current harvest close date and trying to figure out the dates that were going to be audited, and so we have had to delay as we were trying to work around the harvest close and all of that information. So I do apologize for that, but we have our audit kickoff call with our surgeons the end of this month, and then the audit letters will be coming out shortly after that. So I do apologize for that. I don't know if Carol or if you had anything else to add, but
No, I think we're just waiting for some clarification from the task force call that will be used in the planning call that we needed to wait for.
Okay, Dawn.
But I don't know, did we notify? I don't think we notified sites yet either.
No.
I think it's all going to be one. We wanted to make sure we had the correct information in the letter that was going to be used to notify sites before sending them. So
yes, correct. Let's see. Chastity, will the training manual have the new guidance re the Starnes procedure?
Absolutely. And so that will go in the July training manual. So I usually get it to Leanne before the end of the previous month. So before the end of June, we'll get it to Leanne, and then STS gets it posted usually within the first week of the month. So I would expect it there by early July.
Okay. And I know there was a question from Amy regarding the Starnes. And I don't know, I think Dr. Meyer, you had indicated you wanted to respond to this one. Is it okay to include both code 480 and 465 for patients that had a Starnes procedure, or should we just code 480 and any other procedures done during the case?
So I would submit that we just code 480, and you will know that it's for Epstein's disease because that should be in the diagnosis section.
Okay, anybody have anything else?
The only thing I would add to that is if you were to code both, the Epstein's repair is one of the it has procedure-specific factors associated with it, so it would automatically become primary and would completely, then nullify what we just told you. So you really you should only code for 80, as Dr. Meyer said.
Yeah, and I should have added that was another reason for not including the Starnes procedure in the 465 procedure code, because all of the procedure specific factors relate to an actual Epstein's repair, and the Starnes procedure is not an Epstein's repair. It happens to be done for Epstein's disease, but not, but so the procedure, right, the procedure specific factors are irrelevant and potentially will just give us garbage in sort of information. So that's why we took it out.
It's not
You got to turn one of your speakers off, Jeff.
working on it.
No.
There you go.
That work?
Yeah, that's good.
Yep, yes, sir.
Had to be smarter than my computer. It was intellectually challenging for a second.
You worked your way through it, Dr. Jacobs. Good job.
I had to call a consult, but both my kids are away. Yeah, I think what John said is important. A Starnes procedure is not a repair; it's a palliative operation. So by moving it out of the Epstein's repair and into a strategy to code for tricuspid valve exclusion, that really is the correct thing to do, because it takes it out of the repair pile. I think the only thing one could do beyond coding for the Starnes procedure as a tricuspid valve exclusion is one could, in addition, as a secondary procedure, code the type of aortopulmonary shunt that's done. So you could say whether you did a BT shunt or some other, or a central shunt, and that could be coded as a secondary procedure. But it certainly shouldn't go to Epstein's repair anymore. That was a mistake, like John said.
Perfect. Next question from Catherine. I think this is in regards to the 30-day verification. If a patient has a future appointment, does that count?
Not until after they are seen at their future appointment, because you're validating that the patient is alive at their 30-day status. So it really needs to be after that appointment, unless you can see when perhaps the parents called to schedule the appointment, and maybe that occurs post 30 days because they would be, making an appointment for a patient that is alive and can be seen. But so that it really just depends on how much detail you can see within your EHR. But a future appointment does not say someone's alive. It's when they show up for that appointment.
All right. Another question related. Do you have to document separately if Care Everywhere was used within the EMR?
No, you just need to be able to upload the source that you use to show that they're alive. So if you have a document, from within your EHR, however you obtain it, it doesn't matter if it's Care Everywhere, if it was something that was faxed to you by the cardiology office, if it were, you have something that says the patient was alive on this day, which occurs, post 30 days from the procedure.
Will the new version comment section pass through for the auditor to see? So, Carol, I believe those are not harvested fields. I think we set those to harvest no. So if you use those new variables for those comments, I believe you have to do like a screenshot and upload that, correct?
Right.
Mhm.
Right.
Yep. Yeah, because
Because
we made those.
it will not be sent to STS, so it just lives in your software.
Right. What are the audit dates?
So they were in the slides, and so you can definitely reference them there, but it is July 1st of 2020 through June 30th of 2021. Yes, you have it listed there, Beth. Perfect.
Is the 30-day mortality documentation required to be provided for all patients for the audit period or just the audited cases?
So we know that this is maybe new information for many sites or for people that haven't been doing this for a long period of time. If you have not been doing, it is the expectation that you would do this for all patients, especially moving forward. But in preparation for your audit, they're only going to be looking at the randomly selected cases. Now there are 20 randomly selected cases and all the mortalities. So definitely for those two populations, you want to make sure that you have this documentation, but also know that there's overflow. So let's say they identify an index operation that somehow you realize during audit it doesn't meet criteria. There's an overflow pool of 10 additional cases. I would probably make sure that those cases also have this source documentation, so you get your 100% match.
All right. Is the 30-day mortality documentation required to be provided for all patients? Did we just answer that?
Same question. Yep.
We just answered that. Okay, from Cindy, what if the information for verification of mortality has been removed after you documented this as your source, which is out of my control?
I think that that's probably something you need to work with on your site. You have to provide verification of this. So is it something that if you know it's likely to be removed, if they only retain records for so long, or some policy like that, that perhaps you're saving it into a source file in folders in your computer, so you can always go back to this source verification, because you're not going to be able to say that to the auditors, well, for sure it was here last year when I looked at it and now it's just gone. That doesn't provide them with that source of truth. And so you'll need to work through that with your own institution to figure out how to elicit that information.
Maggie had her hand raised. Maggie, did you have a question?
Oh, go ahead, Maggie.
I do. So I keep a spreadsheet that I document on all of my patients what my source was, but it may be something as simple as office visit to pediatric cardiologist on June 21st, 2022. Now, is that adequate? And that office visit may or may not be in my EHR, depending on if that was a cardiologist who is in our health system, or if it was someone outside that I made the phone call to their office.
I mean, I think it's probably as adequate for now as it can be. But if you were to be notified of audit, I personally would go through and figure out who you have EHR solid documentation for versus those cases that you did indeed call. I would think that they might want to see like the date that you called to elicit that information. And I know it would probably be very difficult to go back and figure out, what dates you called and things. Right. But hopefully if you were to look at your cases and then your mortalities, that you're able to elicit the majority of those from your EHR, and it may not then be an issue. And from this point going forward, you can provide the on June 5th, I called. And
but why do they need to know the date that I called? That's not really relevant to the child being alive.
No, I was just,
the child was alive at the office visit.
Being as detailed as possible as to when you elicited the information. But again, I don't think you can go backwards and get that date. I would advise.
I mean, that would be virtually impossible.
Right. Absolutely. So I would say if you get cited a letter for audit and you've got X number of mortalities and you have your 20 random cases, and as you go through and you have documentation of all of those in your EHR, you're done. If there happens to be a case or two that aren't in your EHR and you then know that you called somebody, then you can look at those two cases and make sure you have as much detail as possible. But moving forward, my advice would be is that you have a date, when you call or when you elicited the information, just to be as detailed as possible.
Okay, well, I mean, going forward, I can certainly do that, but like you said, going back retrospectively to try and determine what date I might have called a pediatrician or a cardiologist office. I mean, I would have no way of accurately doing that. So, and generally when I call, I'm speaking to like a front desk person and just asking, has this child been seen on or after this date? Because that's really about all they're willing to tell me. They're, from a PHI standpoint, I don't think they want to give me a lot of detail. So anyway, thanks for the information, Chastity.
Oh, no, thank you, Maggie.
Mhm.
Okay, I think Chastity, I don't know if I think Chastity may have lost her audio.
No, I don't know. It was going
Are
in.
you-
I apologize.
Okay, oh, no, that's okay.
Thank you,
Uh,
Maggie.
Janet had her hand raised. Janet, did you have a question?
I had both a question and a comment.
Okay.
In terms of the audit, it helps if you put the last follow-up date in to match the date in your EMR, so it's easier to track back to what piece of paper you used when you're audited. So that would just be a suggestion. And I have always had to keep an Excel spreadsheet, so you just have the date that you contacted the office. I try to put who I talked to and a little bit of information. So, and that's been accepted. I've been audited a number of times, and that's always been an acceptable source to keep that information. I had one comment about the major complications, because the unplanned cardiac arrest was included on the slide and on page 478, where it talks about whether or not the patient had a major complication. For that quality part, the unplanned cardiac arrest is not listed there. So we might want to just make an amendment to that for the training manual.
Yeah,
Dr. Jacobs, I don't know if you still have the echo. Or, oh, I think we lost him. Oh, no,
how about this?
there you go.
Janet's making a really good point there. When we first published major complications, it did not include the cardiac arrest complication. That was when Marshall Jacobs published a paper called the stat morbidity score. And he made a score just like the stat mortality score, but he called it the stat morbidity score. In that, he had a variable called major complications, which included all of them, but the cardiac arrest variable that was just brought up by Janet. Then when Sarah Pasquale published her paper on the multi-domain composite of mortality and morbidity, the cardiac arrest complication was added into all of the other previously utilized major complications. So it got it that this is one complication that got added into the menu of major complications after they were originally published and developed. So it's probably worth documenting clearly what the current list is.
Thank you. Let's see. All right. A question from Sam. Should care everywhere as method of verification be coded as contact with medical provider or evidence of life or death in the medical record, because records in care everywhere are not your hospital's medical record?
So I know that there aren't definitions associated with each of those selections in the dropdown as to what your source of verification is. And so my suggestion in those times is to just be consistent at your site. So if you're using care everywhere and you say that then that is contact with the medical provider, I think that that's just fine, just as long as if you're using care everywhere across all, many records, that you're answering that question the same way. So if that makes sense, Sam.
Okay. All right. Let's see, why are these details being required for this audit with no notice? I also keep a spreadsheet with notes, but not when I called. And this will only affect a very small number of my patients, but I do like to have all of my ducks in a row.
Take that one, Leanne. This is Carol.
Oh, yes. Sorry.
So Kim, I'm gonna assume that when you say why are all these details being required, that you're referring to the mortality status verification. And the thought this came down from STS leadership and spans all of our databases. The thought is that sites are not just coding 30-day status without doing some research into if the patient is alive or dead, and other things that go into the 30-day status, like readmission for congenital patients. but that you are actually calling the patient and you are documenting that somewhere. It is typical, and Chastity made a good point about making sure you date your entries. If for some reason you ever had to go back or provide your surgeon with information and you surgeons asking, how is this patient doing, you would have some type of documentation with a date and who you spoke to. That's just common, documentation rules for anything we document, is that we include who's documenting it, when we're documenting it, and who we spoke to. Same thing if we just take a message, but on a phone call, we always document that the time the patient called, or who called, what the question was, and who we spoke to. So we do ask for that information, and I'm not sure that it was no notice. I think we've always assumed that sites were doing it. They just have not been sending in that information to us during the audit process, which makes it very difficult to determine if sites are accurately doing this or not. We assume sites are, but we don't have anything to go, or we didn't have much to go by, because they would forget to send in this documentation to us for the audit. So we are making this 100% required. We assume that that nobody is just guessing on the status of their patients, and everybody's legitimately and very meticulously doing their job and checking statuses. We just need to see that information for the audit. So I hope that answered the question, Kim.
From Michelle, can your follow-up status information be used for 30-day status verification? So I think she's referring to,
I'll let Chastity take that one.
or I think she's referring to this, but we need to have documented other than. Hello?
Yeah, it's Leslie. Chastity had to jump off for another meeting.
Oh, geez, sorry about that. Oh, it's after 2. Sorry about that. Oh, hi, Leslie. I'm sorry.
Good, how are you? So as long as it meets the definition, you can certainly, share information across fields. If it's your follow-up status date that you put in there is over 30 days, then it would qualify. Or am I misunderstanding the question?
Well, I think we need to see some type of documentation that the reason why this was coded. How did we know that office visit to provider occurred? When did that occur, and who was the provider, or things like that? Why are we coding it the way that it was coded? How do you know, I guess, is the question. We can revisit this on the next call.
All right, and I didn't even notice the time, so thank you. And thank you, Leslie, for letting me out. I didn't totally lost track of time, so I apologize for that. Again, if you guys have any questions, again, like Chastity, Leslie, Carol said, we can revisit. If you have any additional questions about the follow-up verification, just please, reach out to us, shoot me an email, and we'll definitely get those covered in our next webinar, get those questions answered for you. Again, my contact information, in case you're not aware, is you can just shoot me an email at ljones@sts.org, and I'll be happy to answer any questions for you. So with that, thank you, everyone. Again, I apologize, I completely lost track of time. So thank you, everyone, for joining today. Chastity had a great presentation. This webinar will be recorded, and it will be posted out on the STS website within 2 to 3 business days. So check back out there if you need to revisit the recording. So thanks, everyone, for joining today. I greatly appreciate it. I hope you guys all have a great rest of the week, and we will see you guys on our next call. Thank you, everyone. Thanks, Dr. Meyer.
Thank
Dr.
you. Bye.
Jacobs, for joining. Thanks, Carol. Bye-bye.
Thanks.